I welcome you all on this Sunday afternoon for a very lively session of fat in the liver. We have two leading hepatologists and endocrinologists from India. I'll first be starting from the topic of fat in the liver. Is it a friend or is it your enemy? Then Dr. Anup Mishra, who is one of the leading endocrinologists not only of India but the world over, who is going to tell us what is the role of newer anti-diabetics in so-called fat becoming enemy in the liver. And finally, we have the celebrated hepatologist from Bombay, Dr. Sameer Shah, who is going to take you through the journey of selecting a particular type of drug in a given scenario based on the case presentation in patients with non-alcoholic fatty liver disease. So I welcome you all. Sorry for a bit of delay because of the technical glitches. I think we should be able to make up for the time. What are fats? I think it is extremely important to know in common language. Now, fat in science or biology means it could simply be a molecule, it could be a tissue, or it could be an organ. So everything is called fat. What is the molecular structure of the fat? I think it is very easy to understand. Fats in general are made up of the fatty acid. And what are these fatty acids? These are straight hydrocarbon organic acids. Usually the number of these organic acids, they have even number of carbon atoms, that is 4, 6, 18. This is the way the fatty acids are manufactured in the cytoplasm of the cell. The synthesis of the fatty acids occurs in the cytoplasm of the cells. This is the classical palmitic acid, 18 carbon fatty acid. What is a fat molecule? When we talk of general term fat in colloquial language or in the general public language, fat means a molecule of triacylglycerol or TAG. TAG in science, in our own terminology, medical terminology, is the same thing as fat in the general public. What is it made up of? It has a carbohydrate structure called glycerol, to which 3 chains of the fatty acids are attached. So if you attach glycerol to 3 fatty acids, it becomes triacylglycerol or TAG, in which 3 molecules of the water are removed. So what is the fat and what is its importance in the body? When this fatty acids are attached to the carbohydrate molecule, so it becomes a fat, which is an important component of the diet. So you have saturated fat, unsaturated fat, trans fats. When the same fat has a phosphate lead, it becomes a lecithin. It is an important component of the cell membranes. As I'll show you, cell membranes have a very important protective covering of the phospholipids. And fats are also important components of the integral substances for the formation of all the steroids and hormones without which our body cannot function. So what is a saturated fat? Any fat which does not have any double carbon bond. That means there is no space for an insertion of any hydrogen atom. That is a saturated fat. Now look at this fat, which is monounsaturated fat. We also called it MUFA. It has one bond which has a double carbon to carbon bond at position 3. So you can attach one carbon atom here. So this becomes monounsaturated fat. You have another type of fat which is polyunsaturated. You would have heard of this entity or term called PUFA, polyunsaturated fatty acid. That means you have more than one bonds in the carbon to carbon bond, which are double bonds, which can have intake of hydrogen. So this is a polyunsaturated fatty acid. So what is a fat? Fat is basically a triacylglycerol in our language, which is condensed into various particle components. So this is the fatty acid, which is completely saturated. If there is one single bond, it becomes monounsaturated. And if you can put in 2 more hydrogen bonds, this becomes a polyunsaturated fatty acid or PUFA, which we refer to as. So what type of fat do we have in general day-to-day life? We will have a saturated fat, which is just classical example is butter. It has straight chains because all atoms are packed in a straight manner. It has a high boiling point, and at room temperature, it becomes solid. Unsaturated fat typically have bent configuration, They are less densely packed and hence they are liquefied at temperature. Whereas unsaturated fat have the same characteristic as saturated fats. Where do we get these fats from? We get it from the animal source, especially the saturated fatty acids. Most of the unsaturated fats, we get it from the vegetable oils and trans-saturated fats. This is something which is most dangerous. I'm sure Dr. Anoop is going to tell us more about it. Trans fat is something which is harmful for the body. All these cakes, pastries, and candies have all this processed food has the saturated fat. Let's see what is the journey of fat in the body. Fats are absorbed from the intestines, not into the blood vessels directly, like what happens with glucose and amino acids, but since they are biggish in size, they are transported into the body through this lymphatic system. They are not transported directly, but they have a covering of this lipoprotein. So lipoprotein is a special type of a particle which gives a monolayer to hydrophobic triacylglycerol or fat. So fat is transported in the body with the help of these coverings called lipoproteins. This covering is different in lipoprotein from a cell membrane. Cell membrane, if you see, has a dual covering. It has a covering inside and it has a covering outside of the phospholipids. So it remains hydrophilic inside, as against a lipoprotein molecule which has a hydrophobic inside. In addition, when the fat is traveling in the body, it also with it carries other structures like cholesterol, which are bound to special carrying proteins called apolipoproteins. So this is what happens. The fat which you ingest in the body is absorbed into the lymphatics in the form of chylomicrons. Some of the chylomicrons are picked up by the fatty acid, by fatty tissue and muscles. Chylomicron remnants go into the liver. Liver uses it for a particular purpose. The excess of it is excreted in the form of bile, again for the digestion of the food. Now, let me tell you something which is very common and most of us are still not sure what we are talking of. Whenever you see a lipid profile report and whenever you talk of different type of lipoprotein, we usually do not know what is happening. Let me clarify some of these issues. Chylomicron is a lipoprotein which is formed in the intestines, and as it goes into the fatty tissues, part of the fat is removed and what is left is a chylomicron remnant. These are picked up by the liver, and then liver produces a substance called VLDL, very low density lipoprotein, which is released from the liver. Fatty acids take some part of the fat from this VLDL and convert it into LDL or low density lipoproteins. Low density lipoproteins then go to all the tissues to deliver lipids or cholesterol, whereas high density lipoprotein are produced from the low density lipoproteins. Let's see the function of each of this. The basic purpose of chylomicron is to provide the fat and cholesterol to the rest of the body. Chylomicron remnant are picked up by the liver from the unused fat which is coming from the intestines. The purpose of the VLDL is to supply the body with the fat which is it synthesizes, not the one which has been coming from the intestine. LDL supplies the whole body with cholesterol, whereas HDL takes away the cholesterol from the body back to the liver. That is the reason this is called a good cholesterol. I was Dr. Anoop Mishra's student at AIMS. He taught me why this is a good cholesterol, why this is a bad cholesterol. Today we understand HDL takes the bad cholesterol away from the tissues into the liver, whereas LDL takes the cholesterol from the liver into the tissues. So what is the structure of these? Chylomicrons have 90% fat, 1% protein. And as the size of the lipoprotein decreases, you have more and more of protein and less of fat. So HDL has the minimum fat and maximum protein. So as the size of the lipid particle decreases, the density increases. That is the basic difference between the two. So what is the fate of the absorbed fat which we eat? First and foremost is the fat which we use is used as a source of energy. It can either be stored or it can be used for the formation of the structural proteins. Now, how is it used as a source of energy? Now, let's see. The basic molecular structure of a fat molecule is, it is a TAG or triacylglycerol. It has a composition of C55H104 and O6. And by definition, it will be metabolized in the mitochondria by beta oxidation using a oxygenation technique. So what it is converted into is water molecule and carbon dioxide molecule. So every gram of fat which you eat necessarily gets converted into 80% of the times into carbon dioxide and 15% of the times into water. So in fact, this is the most important source of contaminant of the environment with CO2. Because every time you eat fat, it has to be necessarily metabolized into carbon dioxide. So it is an important source of CO2 contamination. How is it used as a source of energy is that in patients who just depend on the glycogen store, if total glycogen store in a 70 kg man is only 500 gram, 1 gram of glucose gives you 4 calories. So if you're dependent only on your glycogen or the glucose store in the body, you will be able to survive without food for 1 day. But look at what happens if you are dependent on fat. The average 70 kg of human being has a total weight of 12 kg of fat in the body. And each gram of the fat gives you 9 calories per gram. So it gives you 11,000 calories. So 1,10,000 calories. And if you're using 2,000 calories per day, you can live without eating anything for a period of 60 days, only and only if you have fat in the body. If there was no fat in the body, if you're dependent only on glucose, you'll not be able to survive without food for more than 1 day. In addition, when you have a lot of fat, it gets stored in the subcutaneous tissue, in the visceral tissue, and in the bone marrow. In the subcutaneous tissue, it will act as a storage organ for you to use at a time when you need it in the absence of the food. And in the visceral tissue, it is used for cushioning the various important organs of the body like pericardium, heart, lungs, pleura, and your intestinal tract. What about the storage of the fat? In fact, not only that it is useful for storage and energy, it also gives you good component of the structural functions of the protein. It maintains your healthy skin and hair. It maintains the right body temperature. It is important for smooth functioning of the body. It gives you important neurotransmitters and the structural protein for the brain and retina. It is useful for absorption of the food, fat-soluble vitamins. It boosts your immunity and it acts as a shock absorber for the bone. But how is it a fat which is so friendly with you suddenly become a foe? If you look at the latest article, and I think Dr. Anoop has been writing very well about this in all international medical journals, there is a surge of decreased activity and increased consumption of the food. More and more articles you see how to reduce weight, and there is increasing awareness about the obesity. Recent article from Times of India clearly stating that over the last 30 years, the consumption of the human diet has increased by as much as 129%. So what happens? If you have eating too much, more than what you need will tend to store the fat in the aberrant tissues. And once the fat is stored in the aberrant tissues, that means other than your subcutaneous tissue, it starts creating multiple problems. And that is the beginning of the problem, which leads to fatty liver disease and its attendant complication. So what leads to the fatty liver? First and foremost is there is a behavioral problem. You tend to overeat, and that leads to obesity, which causes insulin resistance, fatty liver, and all its important complications. Now let's start focusing on what is the basic problem in patients who are obese. Let's see, in this normal rat, if this rat is fed with glucose, the glucose absorbed in the blood stimulates insulin, which goes to the adipose tissue, which releases a hormone called leptin. Now, leptin goes and gets attached to the receptors in the hypothalamus and tells them that there should be a satiety which should be induced. That means you should feel full of meal. You should be having good satiety and should not be eating more. So this is what happens in a normal person. You start eating chocolates and after half an hour you feel full. But look at this chubby guy who keeps eating. What is the problem with him? The problem is like that of this fat rat. What happens is the leptin which is released, there is something wrong at the level of the receptors in the hypothalamus, which fails to receive this receptor stimulus from leptin, telling it that satiety should be induced. So the person continues to have lack of response to leptin, thereby there is no satiety and the person keeps eating. So this is what happens. In a normal person, when you have fat cells, there are a limited number of the macrophages. And any attempt to cause inflammation is counteracted by stimulation of the M2 type of macrophages, which will produce anti-inflammatory substances. But once you have put on a lot of fat, because of the increase in the number of the Cooper cells and ischemia produced in the Cooper cell, a lot of pro-inflammatory cytokines are released because of the deposition of the large amount of the fat in the adipose cells. Pro-inflammatory cytokines are released, and there is a changeover from M2 to M1 type of macrophages, which produces pro-inflammatory cytokines. So that is the basis of development of pro-inflammatory cytokines, which leads to formation of the fatty liver. So this is what happens. In a person who has a normal insulin in the body, insulin leads to stimulation of the GLUT4 receptor by stimulation of these receptors called tyrosine phosphorylation. What happens with this type of phosphorylation is that GLUT4 receptor, they tend to come onto the surface of the cells, and as glucose is taken into the cells. But in presence of insulin resistance, something happens. This tyrosine phosphorylation is converted into serine phosphorylation, so that the incoming stimulus for the insulin to move the GLUT4 receptor onto the hepatin to the surface is gone. So the receptors are not able to take the glucose in. So there is a persistent hyperglycemia that leads to diabetes mellitus. In addition, the obesity had induced pro-inflammatory cytokines, which also tend to produce insulin resistance by serine phosphorylation. So what is happening is insulin resistance because of the obesity leads to fatty liver. Fatty liver per se will also produce insulin resistance. In normal course of the event, insulin will lead to increased uptake of the glucose in the adipose tissue and deposition of the fat in the liver, leading to less lipolysis. But when you have insulin resistance, which is induced by the TNF produced by the ischemic adipose cells, you have ongoing lipolysis, which leads to a lot of inflow of the fat into the liver, resulting in the fatty liver. So you have a chain of events. Peripheral resistance leads to more fatty liver fat coming into the liver, which produces more de novo lipogenesis. That leads to formation of the diacyl glycerol, which further stimulate hepatic insulin resistance. And this vicious cycle goes on till you change over from a bland fatty liver to an inflamed liver called non-alcoholic steatohepatitis. Once that occurs, that is the beginning of all state of complications. Fatty liver will produce hyperinsulinemia, hyperglycemia, and release of pro-inflammatory cytokines, which lead to development of diabetes mellitus. In addition, fatty liver, because of the insulin resistance, will lead to dysretrogenesis and production of pro-inflammatory cytokines like PAI1 and fibrogen, which lead to development of cerebrovascular disease. Pro-inflammatory cytokines also affect the kidneys, resulting in chronic kidney disease. And finally, fatty liver produces inflammation, which directly can produce hepatocellular carcinoma, or by stimulation of the mitogenic and adipogenic and anti-apoptotic signals can result in not only in liver cancer, but also other types of GI cancer, which are prevalent in patients with NASH. Fatty liver also produces insulin resistance, resulting in number of extra hepatic manifestations, which I'm sure Dr. Anup will be telling us in detail about hypothyroidism, PCSS, that is polycystic ovarian syndrome, osteoporosis, and hypogonadism. So why is it that a fat which till now had been a friend of yours suddenly become your enemy? It is producing fatty liver disease, it causes diabetes, it causes hypertension, it causes cardiovascular disease, it causes chronic kidney disease, malignancies, or endocrinopathies. How is it that a friend is suddenly becoming a foe? So this is what happens. In fact, there are two sides of the coin in patients who take a lot of fat. Fat per se is good enough to maintain your skin healthy, to maintain your body temperature, to have good functioning of your skin, to give you cushioning of the organs, to give you good number of fatty acids and other components to maintain your function of the brain and retina. It helps in absorption of the fat-soluble vitamins, boosts your immunity, but excess of fat gives you plethora of this vicious cycle, starting with fatty liver disease, obesity, diabetes, kidney disease, CVS, etc. So it is a difficult thing to control. So to conclude, ladies and gentlemen, fat is an energy-rich nutrient which is digested and absorbed by a tightly regulated process. Though invaluable in human beings in maintaining health, excess of the diet may lead to a plethora of problems with the potential to affect almost every organ in the body. The initiation of the fatty liver and insulin resistance are crucial initial steps in the disease cascade and need to be addressed timely and aggressively. To sum up, I think this is just like a Me Too movement. As much as you would like to resist this, I think it is a necessary evil. How to come and deal with fat, I think I'll invite Dr. Anup Mishra to tell us what to do about this Me Too problem. Dr. Anup Mishra, please.
Thank you, Anil. I think you have covered. Am I heard?
Yes, sir.
My voice is okay? Okay.
Yeah,
I think you have covered everything so nicely. And although you have relegated many things to me, I think you have more or less covered this subject of fat and in the body in a very, very comprehensive manner. And there is nothing much as far as me to do as far as those aspects are concerned. So what I'll do is I will only concentrate on the diabetes and anti-hyperglycemic, and that too is the recent anti-hyperglycemic agents as far as hepatic fat is concerned, NAFLD, NASH, and even fibrosis. So I'll share my slides. Just hold on.
Yeah, we can see it. Just make it full screen. Yeah.
Okay, so once again, Anil, thank you for inviting me here. My topic is very, very restricted, but I will begin with some general observation and then go on to the effects of anti-hyperglycemic agents in patients with diabetes. Now, this is the background, and the background is that diabetes and liver dysfunction are bidirectional processes. And if there is a diabetes, likelihood that liver dysfunction and non-alcoholic fatty liver disease is coexisting, and if non-alcoholic fatty liver disease or NASH are there in a person, then it is likely that he has dysglycemia. Now, pool prevalence of following in patient with diabetes. So I'm only talking about diabetes. I'm not talking about general population as such. And this is the prevalence in diabetes will be much more than the prevalence in the general population or non-diabetic population. Non-alcoholic fatty liver disease is 55 to 65%, and it may be more in India. I'll show you some data. And more importantly, the density of package of triglyceride in the liver in Indians is much more for the same weight and height as compared to a white person. So BMI of two people, Indian and the Western white person, is same. Waist circumference is same. So in fact, the obesity is same from these two parameters, but body fat in Indians is much more, as Anil has said. And if you look at the liver triglyceride, they are 3 times more in Indian population. So we are much more predisposed to. And similarly, NASH worldwide prevalence, this is the recent data in patients with diabetes, 30 to 40%, and advanced fibrosis is 17%. Now there is a rapid progression from NAFLD to NASH to fibrosis in patients with diabetes also. So as I said, it is a bidirectional relationship, and any diabetologist should have a good knowledge of liver and also how to treat this NAFLD as far as diabetic patients are concerned. Now, this is our recent data, analysis of 250 patients. It's yet unpublished data, but we have used not only FibroScan, but the fat fraction and the MRI to look at how many people, how many patients of diabetes have NAFLD and how many have fibrosis. Now look at this data. This is much more than what I have told earlier. The grade 3 fatty liver on FibroScan is 85% of our patients. Now, we may be different because we have a tertiary care center and it may be different in a primary care center. But as I said, around 60% is the usual data. And very few people have normal liver. Look at this. 1.6% of our diabetic patients have normal liver. Now, if we go further and look at our previously published data on non-obese patients with diabetes. Now, these are newly diagnosed non-obese patients with diabetes compared to non-diabetic control. And we did a detailed analysis of their fat inside the abdomen, subcutaneous fat, liver span, and fatty liver, everything. And then we published some time back. So not only these diabetic patients had a higher intra-abdominal fat and total abdominal fat, and also liver span, which indicates fat in the liver, 50% of these non-obese newly diagnosed patients had non-alcoholic fatty liver disease. So these data are 3-4 years old. And then subsequently, continuing on our recent data, look at that, liver fibrosis in patients with type 2 diabetes. Now, using a fibroscan, 39% only have no fibrosis, which is a worrying feature here, because starting from mild fibrosis to severe fibrosis, there is, the rest of the patients have that. The worldwide data was 17% of severe fibrosis, and we have 18%. So we are matching as far as worldwide data is concerned in terms of fibrosis. And this fibrosis, there are many factors. We are analyzing our data, and we have in multivariate analysis, there are many factors which are responsible for beside diabetes. But age is one thing which is responsible. Look at the severe fibrosis from younger ages to older ages. And here it is almost 19-20%. So age is one clear determinant of severe fibrosis. Now, let's look at the drugs. What are the effects of the drugs on the liver fat, the commonly used drugs for diabetes? Now, one thing I will not be covering because I was told to cover only newer anti-hyperglycemic drugs. So one important drug I'll be leaving, but I will be happy to answer any questions on pioglitazone, because that's perhaps still, if after all these years, is the most effective drug as far as liver fat and liver fibrosis is concerned. But what we have been using recently is large number of patient DPP-4 inhibitors, and the number of DPP-4 inhibitors which are being used. The DPP-4 has a high activity in liver, and this is the the data in the experimental animals. And if you see here in the liver as compared to the rest of the fatty tissue and smooth muscles, etc., there is a high amount of DPP-4 activity. And that's shown in the biopsy, liver biopsy samples also, very high amount of DPP-4. So liver is a good target for DPP-4 inhibitors. But unfortunately, there are not many trials which are available as far as the use of DPP-4 inhibitors in the non-alcoholic fatty liver disease. Good trials are needed. I'll only show you one such trial. But before that, I'll show you some of our data on DPP-4. Now, DPP-4 can be in tissue or DPP-4 can be in the blood. The circulating DPP-4 is injurious, is a poison. It increases inflammation, increases advanced glycosylation end product, and increases insulin resistance, and also produces new onset diabetes. But more importantly, the apoptosis and fibrosis in liver is produced by circulating DPP-4. And what we found was that in newly diagnosed patients with diabetes, as compared to non-diabetic control, circulating DPP-4 was very high. We published that in BMJ some time back. So, like I showed that the Indian patients have more of abdominal fat and more of liver fat, also have more of circulating DPP-4, and high amount of circulating DPP. Whether it's more than Western population, I don't know. There's no comparative data, but this could be injurious to liver, and hence theoretically, a DPP-4 inhibitor should act well. But as I said, there are not many studies. There is only one study which is good, and which is the randomized control trial of sitagliptin in non-alcoholic fatty liver disease in small number of patients for 24 weeks, and this is the fat fraction in the liver at week 0 and week 24, and you can see as compared to placebo, the fat fraction decrease. How much it means as far as fibrosis is concerned, and ultimately other endpoints are concerned, I do not know. But this is the only good study which is available. Now, the second, which is more important, is discussion on SGLT2 inhibitors, and the proof of concept as far as SGLT2 and liver fat is very clear, and has been shown in this particular slide. Now, if you see, this is the experimental animal diabetic mouse at the baseline here at 18 weeks and at 22 weeks, and you can see in hematoxylin eosin and on fibrosis measurement by various, the fibronectin, collagen, laminin, they all increase in mice from day 0 to day 24. And you can see very well, and this fibrosis also increases. The moment you start dapagliflozin from week 18 to 24, the inflammation decreases and fibrosis declines. Dapagliflozin, you know very well, that's a SGLT2 inhibitor. So here is a proof of concept that dapagliflozin actually decreases the inflammation, fat, and fibrosis in experimental animals. Let's go further. And let's look at some of the human data. This is one such study where epagliflozin and pioglitazone were compared in fatty liver. This is a 24 weeks open label active control trial. And as you can see that here the fat was measured by LS ratio. The fat in the liver decreased by both, by pioglitazone as well as by epagliflozin. But as far as the weight is concerned, was decreased by epagliflozin and increased by pioglitazone. So similarly, the transaminases were similarly decreased as far as both are concerned. And adiponectin is increased only by pioglitazone. So there are differential effects in terms of weight, in terms of adiponectin, but in terms of the overall liver improvement, both were similar. Both groups had a small number of patients, and this was a 24-week study. Now, if you look at the EMPA-REG trial, one of the most famous trials as of using empagliflozin, and if you look at the transaminases level over a period of time, this is the ALT level. ALT reduction was observed with empagliflozin and was largely independent of weight loss and hemoglobin A1C reduction. So there fair amount of experimental evidence. There is fair amount of, not a fair amount, but some amount of the human trials. And this is our data. There's a dapagliflozin in 15 patients over a period of 120 days. These are the 15 patients, their weight circumference, a difference, but liver fat fraction using MRI was decreased in everybody. And some patient more. Look at this patient where I have outlined 17% decrease in the protein, the fat fraction in the liver. So average, everybody benefited, some less, some more. If you look at the meta-analysis, this was published some time back as far as fat reduction is concerned, and as far as reduction in fibrosis is concerned, there are a number of studies, including some from India. Most of the studies using either empagliflozin, epagliflozin, lusigliflozin, and dapagliflozin showed improvement as far as these two parameters are concerned. Remogliflozin, which is recently introduced in India, and is a cheap SGLT2 inhibitor. There are not many studies are available as far as cardiovascular outcome is concerned with the remogliflozin, but this is a good experimental study in the mice which were given high-fat meal and their liver enlarged and the ALT went up and remogliflozin decreased that. This has been shown fatty droplets also increased, triglyceride content. In fact, it has a very strong action on decrease in the hepatic triglyceride. So, but there are no human data available. Now, perhaps the most important agent is GLP-1 receptor agonist. And again, some experimental data which show in OB mouse that the GLP-1 receptor agonist exending 4 reversed hepatic steatosis. This is old data. Then this is the human data. This is liraglutide multi-center randomized double-blind trial, phase 2 study. 26 patients each treated for 48-week dose of 1.8 milligram per day in liraglutide. 39% in the liraglutide group had resolution in the NASH on liver biopsy, and ALT and gamma glutamyl transfer decreased. There is some data comparison of liraglutide, metformin, and gliclazide, and it was shown that this is a small study. Liraglutide and metformin decrease aminotransferase and the weight, and so liraglutide is faring well as compared to other agents is concerned. And there are some other trials which are going on, award program with dulaglutide and with the semaglutide NASH study, and the results of which we'll be having soon. So finally, a couple of slides on mechanism. And if you see here, the GLP-1 receptor agonist decreased fatty acid oxidation and de novo lipogenesis. DPP-4 decreased apoptosis and fibrosis. SGLT2 inhibitors, they decrease glucose and the triglyceride from the fat went out. And there are other agents, pioglitazone I have not discussed. Imiglimin, which is a good agent for liver, which is yet in experimental stages, and KHK inhibitor, which is in the pipeline. So this is my final slide, that pioglitazone is of definite benefit, improves histology. Vitamin E role in diabetic patient is unknown. Bariatric surgery role is definite, it improves histology. Liraglutide role is emerging, it improves histology. And SGLT role is also emerging, possibly it also improves histology. So with that, I finish my presentation and I'll be happy to take on questions subsequently.
Thank you, Professor Anoop, for a very elegant predisposition of the present concepts on newer diagnostic agents as well as the newer therapeutic armamentarium in patient with NAFLD. You have very elegantly told us the mechanism of action and limitation of the currently available new anti-diabetic medication. I will come to the question answer session at the end of the third talk. May I all request all the participants to please keep typing their questions in the question box provided, so that at the end of the 3 presentation, we'll start answering your queries. May I now request Professor Samir Shah to have a case presentation and then accordingly tell us how to choose an effective therapy for patient with NAFLD. Dr. Samir Shah, please.
Sure. Thank you, Anil. By now you have heard what is fat and how it damages the liver. You also have noted the anti-diabetic drugs. The issue is now how to assess the severity of NAFLD and how should we go about treating it. So all of you know that fatty liver alone is at one end of the spectrum, and then once inflammation sets in, it becomes NASH, which can progress to fibrosis and cirrhosis. So this is very important to understand, that if you have fatty liver alone, the prognosis is much different, the treatment is much different compared to steatohepatitis once it sets in. So how will a patient come to you? Patient will come to you either with a sonography report of fatty liver or a report of elevated liver enzymes. If either of these is present, Then what you would like to do is to find out the cause of either the fatty liver or elevated liver enzymes, and you would ask specific questions to rule out hepatitis B, hepatitis C, autoimmune liver disease, drug-induced liver disease, alcoholic liver disease. And if you have none of these, and if you have fat in the liver with elevated liver enzymes, then this is what points to fatty liver disease as the cause of the elevated liver enzymes. Next, what you would like to do is to ensure that this patient has got metabolic syndrome or not. And all of you would know how to assess metabolic syndrome: waist circumference, triglycerides, HDL levels, hypertension, and diabetes. These are the ones which you will look at. And then comes that if you have a patient whom you have identified with...
I think Dr. Samir possibly has got disconnected.
Anil, we can take questions during this time.
Yes. Okay. Till the Samir joins back, we have a set of questions. First is for Dr. Anup Mishra. This question is: non-obese 40-year-old male with simple ultrasound finding of fatty liver. What will be the approach in this gentleman? Would you like to give them pioglitazone, or would you like to look for evidence of fibrosis on fibroscan?
This 40-year-old is with diabetes or without diabetes, I don't know. And fatty liver, we don't know about the grade and we don't know about the fibrosis. So let's take two scenarios. Like, let's say 40-year-old with diabetes, and you do a fibroscan that is a grade 2 grade, and non-obese fatty liver is very well known. So grade 2 or grade 3 fatty liver, and there is some fibrosis. Of course, we will. Should be. Oh, Dr. Saab is right here. So we'll answer that question later on.
Okay. Yeah, Samir. Yeah.
Was I audible in between, or it was?
No, you had got disconnected, I think.
Oh, okay, fine. So quantification of fat in the liver you can do by ultrasound and by CT scan. However, ultrasound and CT will not differentiate fatty liver from NASH. What is important for us to decide is whether this fatty liver has got significant underlying liver disease. We would logically say that if the SGPT is elevated, then it would mean that there would be significant inflammation in the liver. But what all of us need to realize, that the definition of upper limit of normal has been changed now to 30 in males and 19 in females. So irrespective of what the lab will say, either 40 or even 65, the upper limit is 30 in males and 19 in females. So how will we now decide what to look out for? A person who has got fatty liver disease, how do we know whether there is significant problem? The single most important factor is fibrosis in the liver. So if there is fibrosis in the liver, then it is directly associated not only liver-related complication, but also cardiac complications. How do you assess fibrosis in the liver? So there are three simple ways by which you can assess the fibrosis. Obviously, liver biopsy up till now has been considered gold standard, but you don't need to do to assess the fibrosis. So fibroscan is there. Then the routine ultrasound has got a software and a hardware which can tell you by acoustic radiation forced impulse about the fibrosis, and an MR elastography. So MR elastography assesses not only fat and quantifies the fat most sensitively, but also assesses the fibrosis in the liver. So at Global Hospital in Mumbai, we have regularly done MR elastography in assessing patients with fatty liver disease. And we have found out that if you have a score less than or equal to 2.9, then this is fat alone. If the score is between 3 to 4, then this is fat with inflammation, NASH. And if it is more than 4, then it is NASH plus cirrhosis. Everybody will not be able to do the MR elastography or even fibroscan NRF. So there is a simple way in which you can assess the fibrosis, and it has now been validated, called FIB4. FIB4 is fibrosis 4. 4 because there are 4 tests which are involved in the 3 tests and 1 parameter. So age, platelet count, SGOT and SGPT. So there is a formula you can easily feed in your computer and that will give you the figure. So FIB4 value of less than 1, you can be reasonably sure that this is fatty liver only without any significant inflammation. Anything between 1.3 to 3.25 will be NASH, and anything more than 3.25 will be NASH with cirrhosis. So this is how you go about after we stopped at finding out a person with fatty liver and elevated liver enzymes. You will do FIB4, and if it is less than 1, then you do not need any other specific medicines for the liver. Just diet, exercise, weight reduction and control of metabolic factors is all which is required. I think if I can give this one message in my talk, I think that is enough. So let us see now cases. I'm supposed to have case-based discussion. So the first one is fatty liver with liver inflammation, liver enzymes elevated, and normal fibrosis score. So it's a 20-year-old male. The metabolic alterations are he had BMI which was elevated and he had dyslipidemia. Liver function wise, he had elevated liver enzymes, but we had done an MR elastography. And MR elastography did not show any fibrosis. As we said, it was less than 2.75. It was 2.2 in his case. So there was no significant inflammation or fibrosis. But MRI PDFF, the amount of fat was 11 to 15%. So he did have a fatty liver and his SGPT was 75. His lipid parameters showed triglycerides was 245 and these weight was 81. So he had a high BMI. Just with diet, exercise and weight reduction, you will see that the MRI PDFF fat came down, the triglycerides came down, and with diet and exercise his weight came down, and with that the liver enzymes became from 4275 to 2725. So nothing else was required, no medicine for the liver inflammation, just diet, exercise and weight reduction. That itself sorted out all the problems. So this is important. If you lose more than 10% of your weight, you can even reverse fibrosis. If you lose around 7 to 10%, then you can improve the inflammation in the liver. If around 5% of weight if you lose, then there is improvement in liver fat. So yes, lifestyle modification is very important. Unfortunately, most patients are unable to sustain it for long term. Second case, fatty liver with elevated liver enzymes and stage 2-3 fibrosis. So this is a 47-year-old male. He was again obese by the Asia Pacific cutoffs with dyslipidemia. He had elevated liver enzymes and fatty liver with MRE score of 4.6. Important thing to realize is that he had MRI PDFF of 6 to 10%, which is in the range of fatty liver. His SGPT was 57. He had increased LDL and triglycerides and his weight was 85 kilos. What we did was, along with diet and exercise, we gave statins and ezetimibe. Along with that, because he has elevated MR elastography score, we added vitamin E. We will go into which are the drugs which are helpful for the liver. Pioglitazone was one which Dr. Anup Mishra has mentioned. Vitamin E is another one. Saroglitazar is now licensed for use in NASH. Earlier it was licensed for use in diabetic dyslipidemics. I would like Dr. Anup Mishra to mention his experience, if any, and Professor Dr Arora to mention his experience with saroglitazar. So these are the drugs which we could have given to help the liver. He was given vitamin E and statins, and with that the MR elastography score over a period of 2 years came down from 4.6 to 2.9 to 2.6. So you can reverse the inflammation. The enzymes also, the SGPT came down from 57 to 40. Now you will realize, unfortunately, we have no lipid profile recently done. We have asked him to get a lipid profile done, but he has not lost weight. So he needs to lose weight. You can't just think that the drugs are going to help. The drugs will take care of these lipids. The drugs will take care of the liver inflammation, but you need lifestyle modification to sustain these effects. So that is very important. Weight reduction is important. Next, we talk about bariatric surgery. If there is anything which has really proven to reverse NASH and fibrosis, it is bariatric surgery. There are many types of bariatric surgery, but in a person with liver disease, especially if he has got fibrosis, the only surgery which is recommended is sleeve gastrectomy. It can reverse NASH in patients and even reverse fibrosis. If you have a patient with cirrhosis and clinically significant portal hypertension, then you cannot do any surgery. Roux-en-Y bypass is contraindicated in cirrhotics because patients have deteriorated with liver failure requiring liver transplant. So yes, bariatric surgery is important. It can reverse NASH, but you need to be careful. So clinical scenarios for patients requiring bariatric surgery. First case is a BMI of 47. He was non-cirrhotic and morbidly obese. This is the person where you can consider definitely sleeve gastrectomy. However, Roux-en-Y gastric bypass may be thought of cautiously, but as I said, it is impossible to predict which patient is going to land up with problems. Bariatric surgeons do not have a bad experience, but we hepatologists see patients who have undergone bariatric surgery and come to us with problems. The second is a person whose BMI is 37 and who has a NASH on these investigations. This patient, there is no portal hypertension, so you can go ahead with a sleeve gastrectomy. The third patient is cirrhotic with portal hypertension. Even though we would want to treat this patient, we cannot consider bariatric surgery because any cirrhotic with portal hypertension can decompensate after the surgery. Here is a case now of patient who has got a metabolic syndrome but already gone on to the stage of cirrhosis. So this lady was incidentally detected to have NASH cirrhosis on ultrasound in 2015 when his brother was noted to have fatty liver disease with hepatocellular carcinoma. So the first presentation can be hepatocellular carcinoma of NASH, and it can be familial. The patient, despite adequate control of lipids and diabetes, gradually deteriorated and developed ascites since 2016, which became intractable. She did not have any variceal bleed, portal vein thrombosis or hepatocellular carcinoma. She was assessed and listed for cadaver transplant, and fortunately she could get a liver transplant in 2016. Post-transplant, she has been stable, fortunately. Fortunately, again, the MR elastography which we did post-transplant does not show any fatty liver or fibrosis. However, it is important to realize that patients who have been transplanted for NASH, they are at a high risk of developing NASH and fibrosis post-transplant also. So you need to be very careful. So this is the algorithm which we sort of look at. As I said, we need to distinguish between fat alone, NAFLD with NASH, and end-stage cirrhotic. The first group, NAFLD alone, the physician and the endocrinologist is the person who is the center stage, because here we are not talking about the liver related issues, because the liver related issues will take at least 10 years to come. What is important is to look after the metabolic factors well and to reduce the cardiac morbidity. In the center, once a patient develops NASH, then not only metabolic factors are important, but also we need to know how to reverse NASH or fibrosis. And that is where new drugs we will need to consider. There are a lot of new drugs which are in the pipeline for either getting license for use. The only drugs which are available as of now for our use is pioglitazone, vitamin E, and saroglitazone. These are the three drugs which we can use effectively. Once the patient has become cirrhotic, then what we have to do is to manage this complications of cirrhosis. So approaches for currently available treatment are lifestyle modification, treatment of metabolic factors, and liver-directed treatment. These are the three main sort of treatment modalities which we have to look at in all patients who have fatty liver disease as a presentation. This is not just a hepatologist treating, this is not just an endocrinologist or a physician treating, but it is a multidisciplinary approach. Only then we can have the patient improving with a clinical nutritionist and a dietitian, a physical therapist, and a counselor to counsel in case of any psychological issues. So this is how we will have to distinguish patients with fat alone and fat with liver inflammation and have a multidisciplinary approach for treating them. Thank you.
Thank you, Dr. Samir, for a very elegant presentation of our approach as a hepatologist to a patient who comes to you incidentally with the diagnosis of fatty liver disease on ultrasonography. So what Samir has told us, it's not that we should have a prismatic view of looking at fat alone, but we have to look at the concomitants of the fat in terms of the metabolic factors like diabetes, hypertension, obesity, and the extent to which this fat has caused havoc to the body. So certainly we on our own may not be competent to handle all patients in terms of the metabolic syndrome, because I believe most of the hepatologists may not be good at treating diabetes and hypertension, and hence we consistently need the service of an endocrinologist and a good physicians to be with us. So as he rightly said, it is a multidisciplinary approach to give best to our patients who need it the most. So with that, I'll still request the audience to please keep posting their question onto the question box which is provided to them. And meanwhile, we'll set the ball rolling. And coming back to Dr. Anoop, still the first question you have to answer that 50-year-old male with diabetes and confirmed NAFLD with fibroscan positive, which anti-diabetic medication will be a better choice both for treatment of NAFLD as well as for diabetes? And which one do you think should take a precedence? Should control of diabetes will be more important or control of suppression of fibrosis will be more important? Dr. Anoop, please.
Thank you, Anil. The thing is, we go by several parameters. So one is diabetes, how uncontrolled it is. It's a 400, then blood sugar is around 400, that gets a priority. If diabetes is fairly controlled and the BMI is high and the waist circumference is high, our priority is decreasing weight, as Dr. Shah has said. That will itself lead to amelioration of fatty liver. Which way you can do that? You can do that with a very low calorie diet, and that works in many people, and the weight decreases drastically along with the exercise. As far as drugs are concerned, we are heavily in favor of using SGLT2 in such patients right away. And especially in fibrosis, grade 1 fibrosis, grade 2 fibrosis, we are universally using SGLT2 inhibitors. And if the BMI is 35 or more, or there is a problem with SGLT2 inhibitors, we are using the GLP-1 receptor analog. Now, GLP-1 receptor analog, there's a problem because it is a costly medication, it is an injection, and so on. And sometimes we are combining the two. And you're using a FibroScan. We have got now data, we are going to publish that. Using a FibroScan, we have shown 80% of the people up to fibrosis grade 2, which improve. Even in grade 3 and child A cirrhosis, we have used SGLT2 inhibitors and we have used GLP-1 analogs, and we are going to publish that also. But we are, of course, not going beyond that. So I think these are very, very useful drugs. Unfortunately, Dr. Shah has asked me about saroglitazole. I have some time back we wrote in Lancet about reservation about saroglitazole, and because the dual agonists, earlier were banned in the United States because of sarcomas and so on. We have no data about safety of saroglitazole over a long period of time. Now, if you look at the data, what is the largest data or longest data? Is 56 weeks with saroglitazole. Again, it has not been published in a good journal. There are abstracts and here and there. Robust data, somehow I'm not very convinced about, robust data coming out of saroglitazole. Now, if you look at the vitamin E data, New England Journal of Medicine, Piven study, Sanyal's data, then subsequently QC's data on NAFLD with the vitamin E and so on. These are such robust, very well done studies. One study, Piven study, and we have been using vitamin E subsequently for 10 years now. So a good study is warranted. That's where we are as far as saroglitazole is concerned. I'm sure Dr. Sareen is also doing a lot of trials and so on. We'll see about that. But for the time being, I'm quite satisfied with my practice using these drugs, and we have been able to benefit most of the patients.
And the second question again to Dr. Anoop is, does NAFL alone in the absence of the heart disease to begin with, can itself lead to development of the heart disease because of mere presence of the fat? I'm talking about bidirectional relationship between the two.
Oh, it has been, there's a lot of data about that in the world about the very close approximation of NAFLD and the heart disease. And there is data, Anil, you will be knowing, Naval has, from All India Institute, has produced some surrogate markers of atherosclerosis and NAFLD, and shown that endothelial dysfunction, etc., is much more, artery atherosclerosis is much more in those with the higher grades of fat and so on. So there is no doubt that both are very, very closely interlinked. And if somebody is obese and has a significant amount of fat in liver, we certainly should do something more as far as investigation of atherosclerosis is concerned, whether you do a carotid Doppler or whether you do a ankle brachial index, and some, it depends on you, but certainly that needs to be kept in mind.
Okay. Samir, there is a question for you.
Yes.
What is the cutoff point for FibroScan to say it is a significant fibrosis?
So cutoff
will depend on the etiology or concomitant problem, like if you have diabetes, without diabetes, obesity, without obesity?
So yes, the cutoffs are for different etiologies. The cutoffs are different. In fatty liver disease, if you have 9 to 11 as the figure, then it would be F2, F3 fibrosis, which is what we are wanting to identify in these patients. So we are not worried about F0's fibrosis, and it may overlap with F1. Nothing is so clear-cut black and white. So these are all overlapping figures. So anything between 9 to 11, I would worry. Anything between 11 to 14, it is going towards significant fibrosis. And more than 14, then we are talking about cirrhosis.
Okay. Another question for you is, a patient has both diabetes, NAFLD, and chronic prostatism. There has been a lot of literature on vitamin E linking it with higher risk of prostatic carcinoma. Beyond the age of 55, would you be wary of using it?
So I think use of vitamin E has been very clearly sort of recommended in few situations. And the rest we will need to wait on a case-to-case basis. If we are worried, then I think it is best not to give. But there is more and more data now that the diabetes and cirrhotic patients also benefited when it was looked at. So this is Naga Chalasani's paper which came out. So earlier we had said that only non-diabetic, non-cirrhotic. But even diabetes and cirrhosis also benefits. So yes, we can liberalize use of vitamin E, but if there is a person with prostate problem, then obviously we are concerned.
Yeah, Dr. Anoop, you wanted to say something?
Yeah, there are three situations here. One is the patient who's non-diabetic, and we take examples of PIBIN study, and we restrict vitamin E to 800 milligram per day for 6 months. And usually our practice is in a non-diabetic patient, if we give vitamin E, we are not going beyond 6 months, although there have been some studies beyond that. The second thing is diabetics and vitamin E. Now, QC is a study which has compared placebo with vitamin E, and vitamin E plus pioglitazone showed no benefit of vitamin E as far as diabetics are concerned. And this is a fairly 5-year study and over 18 months, a fairly good study, and QC is a good investigator. So although this has not shown anything, but as Dr. Shah has very well said, I have been using vitamin E in diabetic patients also. I'm shown some improvement also, but I am restricting it to 6 months and stop it after that. Now, as far as risk for prostate cancer has been shown in some studies, and people themselves read it and come back to me and say, well, I may get prostate cancer. I said, I'm restricting it for 6 months. And if you benefit in 6 months, that's fine, well and fine. Otherwise, we'll go to something else.
Yeah, another basic question, Dr. Anup, is how the hell on the earth in a NAFLD patient, which has a basic problem of leptin resistance, metabolic alteration, how will ever a 6 months therapy with an antioxidant ever be useful?
I often wonder, like you, Anil, I'm myself surprised about how vitamin E actually acts, and antioxidants and this and that. But Anil, we have to believe the data, which is a biopsy proven data, as the Sanyal and Kusi, and so I will go only by data. But I will continue to debate how this will. Now, most of the studies which have compared vitamin E, and even PIBIN study and pioglitazone, have shown that pioglitazone actually hits at the basics, and that is insulin resistance. Although it may increase weight, but insulin resistance decreases, liver becomes better. Vitamin E insulin resistance does not decrease, and so that's where it is not working. So if we think that we are going to better liver and thus better insulin resistance and hit at the pathophysiology of diabetes, we are not going to do that with the vitamin E. You are absolutely right.
In any case, any chronic illness which is persistent will certainly have an injury which is related to ROS, that is reactive oxygen species. So there is nothing sacrosanct about vitamin E or any antioxidant. So won't it be useful or useless in any other chronic inflammation, say like rheumatoid arthritis or SLE? Everything has to go on. You see, the reason you get an injury is because you have depletion of antioxidants. So be it alcoholic hepatitis or cirrhosis of the liver or non-alcoholic steatohepatitis or viral hepatitis. Once you get depleted with antioxidants, you have injury. So what is sacrosanct about vitamin E in NASH?
See, only thing, Anil, I see it that this way, that this is easily available, this is cheap, and this, we can give and see. That is the only thing. But I do restrict up to 6 months.
Next question is again addressed to Dr. Anup. How to manage NAFLD in non-diabetic, any role of saroglitazone, pioglitazone, metformin or other? How do you aim to reduce weight? What is it related to medication, or is it related to lifestyle modification, or a combination of the two?
See, if a patient is non-diabetic and obese and has fatty liver, then of course, diet and exercise remains number one. There is no doubt about it. But there are many other ways of weight reduction, and we were using orlistat, we were using lorcaserin till lorcaserin has been banned. But if a patient has marked obesity, then we are using SGLT2 inhibitors. Sorry, not SGLT2 inhibitor. The GLP-1 receptor analog, liraglutide, which has been licensed for use in obesity in the United States in different doses. We don't have that doses, but we are using it off-label, having informed the patient that this has been used in obesity itself, though you do not have diabetes, it is an anti-diabetic drug, but it is the best as far as any drug is concerned, as far as weight reduction is concerned. Now, the second thing which we are doing off-label is patient who is markedly obese, not diabetic, but is a pre-diabetes state. Many of them, 99% will have a pre-diabetes. Let me tell you that if they are not diabetic. In such patient, we inform them that we have a drug which works in diabetes, but works also for liver and works also for weight, and that is SGLT2 inhibitor. Are you ready to take it? So most of the patient will say yes, and we have used it with a great degree of efficacy in reduction of weight, waist circumference, as well as the grade of fatty liver and even reversal of fibrosis.
Dr. Samir, do you think the time has come when hepatologists must learn to treat diabetes, especially with the new upcoming drugs like SGLT2 inhibitors and GLP-1 analogs being the future of therapy both for diabetes and liver?
So that is why I put my slide that if it is fatty liver alone with metabolic syndrome, I think we should keep away and let the endocrinologist or the physician manage, because there are many more issues than the liver at that stage. And optimizing therapy for the metabolic syndrome is more important, which they are specialists at, not we. So rather than we learn, let them look after, but they should send the patient for assessment of fibrosis if they find any of the FIB4 or any of the non-invasive fibrosis modalities suggesting that there is now fibrosis setting in. That is a time we would be having clinical trials where we can enroll them, or an insight as to how to treat fibrosis in the liver. Obviously, if the patient is cirrhotic, then we will have to manage and take help from the endocrinologist. At that time, there are very few drugs in decompensated cirrhotic for diabetes, so it's mainly insulin only which will be of use.
Any role of hepatoprotective agents? You see, if you look at the pathogenesis of NAFLD, most of it is through ROS, through pro-inflammatory cytokines, to lack of antioxidants, to membrane destabilization. So why not use drugs like, say, Heptrol, which gives you, metadoxin and methionine supplements? So what is wrong? Why shouldn't they be effective? If vitamin E can be effective, why not these?
So they need to be proven to be effective for us to use, because as you rightly said, it is not just 3 months or 6 months which these patients will be on. This liver inflammation will take time to go, and as soon as you stop the medicines, the liver inflammation is going to come back. So we need to know for sure whether these medicines are working rather than give an empirical liver tonic.
Do you ever use hepatoprotective drugs in your practice?
So ursodeoxycholic acid I have not used specifically for NAFLD, because there was a large multi-center study which did not show its effectiveness. Rest, as you rightly said, all the drugs which are effective in protecting liver are hepatoprotective, which is vitamin E. So I think those which are working should be used.
Okay. There's a question addressed to Dr. Anup Mishra. Are all DDP4 inhibitors beneficial in NAFLD? With sitagliptin, there is some evidence, but with vidagliptin is rather not to be used in moderate hepatic insufficiency.
Sometime back, I reviewed the whole literature, and there are two parts of the literature. One is clearly directed towards NAFLD, NASH, and early fibrosis, and the second is the CLD, proven CLD with the endoscopy and everything. As far as DPP4 inhibitors are concerned, the data are not too much, as I upfront I told you. But if you take one by one, let's take vildagliptin. Vildagliptin, there is a clear warning that in patients with liver disease, there is going to be, it'll cause problem, and it has been shown in early studies that it may increase transamerases, and hence I am personally not using vildagliptin or taking it off even at the moment patient has fibrosis. So vildagliptin is out as far as that is concerned. Number two, the linagliptin. Now, linagliptin, there are some data to show that in various degrees of liver disease, it does not require any change in the doses, and that it does not cause any deterioration of liver function and so on. So linagliptin can be used, it is safe, but it may not do anything as far as liver is concerned. It may not improve anything. So we are left with only one, and that is sitagliptin. As far as saxagliptin is concerned, we have stopped using saxagliptin. As far as teneligliptin is concerned, I personally don't use it because there are hardly any data overall what to talk of a liver disease. So whenever a patient with a fibrosis comes in and I have to use a gliptin, it is number one sitagliptin and number two linagliptin. There is no other gliptin.
And Dr. Anup, fatty liver disease, NAFLD, and diabetes are almost completely married to each other, especially with these new drugs like SGLT2 inhibitor and GLP-1 analogs going to be the future of pharmacotherapy of NASH and diabetes. You think, are we writing the obituary of rest of the pharmaceutical agent in diabetes in patients with liver disease?
I think so. Anil, these are the future drugs. These are the future drugs, and there is a, even there is a potential of displacing metformin as a frontline drug with the SGLT2, and there are already some guidelines which are coming. Now, I did not show you the last slide, which is the ADA ESD algorithm for using the various drugs, and where if there is a proven atherosclerotic cardiovascular disease, you use SGLT2 and GLP-1. If there's renal failure, use SGLT2. Hypoglycemia, you use this. And people have not got a trajectory for liver disease in this algorithm at all. Zero. There is nothing there. And we are currently, Anil, our center, our trajectory besides cardiovascular disease is liver, is the next trajectory. So I think in future guidelines, there should be a separate trajectory that if you have NASH, if you have fibrosis, then what agent you should use. That should be part of American Diabetic Association, European Association Study of Diabetes algorithm for treatment of diabetes.
Dr. Samir, there is a question for you. What is the status of recently available drug, obeticholic acid? Lot of hype, lot of hope. Where does it stand now?
So obeticholic acid was marketed in India for primary biliary cholangitis. However, the hopes were that we could have used it in NASH, but it has not got the US FDA's approval. So till we get approval, obeticholic acid, although it has a lot of data, it is as yet unapproved for its use in NAFLD NASH.
There is one thing I'll add there to Dr. Shah. What Dr. Shah, there is an increasing concern about LDL increase with obeticholic acid, and that remains. If that is so, that is a problem as far as diabetic patients are concerned, where we are trying to reduce LDL and something is going to increase LDL.
There are one more issue, Dr. Anup, in that not only does it increase HDL, but it also decreases HDL. That is another important issue. So three major issues with OCA are it decreases HDL, increases LDL, and it also causes pruritus. In fact, the very reason the patient comes to a hepatologist, he has dyslipidemia with fatty liver. You add a drug which increases the dyslipidemia, both decreasing the good cholesterol and increasing the bad cholesterol. That's not good. So we still need more data. And Dr. Samir, I have a question for you. Any benefits of tocotrienols over and above tocopherol, like in vitamin E? Any difference between the two?
So these are generic ones. I think you will be able to answer better whether there is any specific difference between the two. No.
See, in terms of efficacy, there is none. But my only question, which I have been repeatedly concerned, is what happens after 6 months? My own impression is if I have 100 patients of non-alcoholic fatty liver disease with me, 90% have only fatty liver, 2% will have NASH, and 8% will have cirrhosis. Is that right? So what do we do for 90% of the patients? So we cannot put them on vitamin E if they have fat. What happens after 6 months? I think most important aspect of management of NAFLD is still lifestyle modification and weight.
Absolutely.
It has to be a persistent lifestyle change, not a time-bound pharmacotherapy or behavioral therapy.
Very true.
Unless you stick to it permanently, you're going to land up with the problem, because we still do not know what is wrong with the receptors at the insulin level, at molecular level, at surface level, what is wrong with adiponectin, leptin axis, because that cannot be rectified. The only thing you can do is to sensitize your own body with the help of lifetime and exercises. So vitamin E 6 months, either way, I'm not able to convince myself it will ever be useful.
Sure.
Next question is, UDCA still, does it have any role?
I think I answered that. In a multi-center US study, it did not show over placebo any beneficial action. So it is not specifically useful in NASH.
Dr. Anup, in a patient who comes to you with mild diabetes, which can be easily controlled with lifestyle modification, but he has significant obesity and say grade 3 fatty liver, would you like to put him on any pharmacotherapy?
It depends on the motivation of the patient. Now there are a couple of patients we say, I will get back to you in 6 months with 10 kg weight loss, and they do that, and they are doing everything possible that we tell them. Now there are some patients who will say and not do it. I cannot identify them, and some patients say, I can only walk for half an hour. There is a problem with my diet control. Whatever you say, I will follow for some time, and I will not follow. So these are three different types of patients. In the patient who's frankly non-compliant to begin with, I will veer towards the pharmacotherapy. And a patient who's very well compliant and does not want to take drug, I will respect his wishes and wait for 6 months.
Anup, there is a question for you. Serum creatinine of 3 with diabetes, 48-year-old gentleman, NAFLD. What will be the drug of choice?
Well, very, very difficult here. The serum creatinine, gives me a major roadblock, and I cannot use the SGLT2 inhibitor. I cannot use GLP-1 analogs. In fact, I cannot use most of the drugs here. And I will only, if a patient is willing to do lifestyle, I am going to rely only on lifestyle measures here. And maybe, although you don't believe in vitamin E, we can give vitamin E in this patient. Now, at a creatinine of 3, there is only one drug that we can use that has been licensed for use and which will benefit liver also, which is pioglitazone. Now, pioglitazone, though licensed for use in any kind of creatinine, will create problem in many patients, will cause fluid retention. A patient has a heart problem, then the patient may go into congestive heart failure, and bone problems may also occur. So one has to choose very carefully whether your target now is actually liver, or creatinine and heart becomes your first and second target, and liver becomes a third target.
And a final question before we call it a day is to Dr. Samir. Dr. Samir, saroglitazar tends to correct the dyslipidemia in patient with NAFLD. So is it worth trying a combination of OCA, which worsens dyslipidemia, and saroglitazar, which tends to overcome it, so that it is beneficial both ways in patient with NAFLD?
So OCA as yet is not approved for use, so that question doesn't come. If once it gets approved, then I think statins and OCA is the combination which probably would be sort of recommended, because in these studies they had seen that the patients who were on statins, these lipids were controlled during the study. So that is the first comment. If a patient has got diabetes, dyslipidemia, and elevated liver enzymes, if the patient goes to a hepatologist, I think the hepatologist is going to start saroglitazar. But my endocrinologist, like Dr. Anup Mishra, they all feel that there are better drugs than saroglitazar to optimally control the metabolic derangements. So that is the thing. So it's neither a good anti-diabetic drug nor anti-dyslipidemic drug. So whether it should be given at all, or we should just control diabetes and dyslipidemia and see what happens.
I have just one comment here. Thank you, Dr. Shah, for clearing that. There are problems in patient understanding now. Now, a patient goes to you or Dr. Arora and saroglitazar has been put, and they ask you, what is it about? It decreases lipids also. And what patient does is to stop statins. Many of the patients come back and say, this is the drug which you are using for cholesterol and lipid, and I have stopped the other one, which is a problem because statin will save lives. Statin will also not be a problem for the liver, in fact, may benefit liver, and statin will prevent a heart attack. So when you are prescribing or anybody is prescribing saroglitazar, this is statin, it must be expressed that statin must be continued.
Okay. Thank you, Dr. Anoop. And with that, we come to the end of the formal presentation. I think we will have to leave one message each from our learned speakers, starting with Dr. Anoop. If you have to give one-liner message on the talk, then on the NAFLD and the fatty liver disease.
My one-line message is that if a patient is disciplined and does a good lifestyle and exercise, most of the NAFLD can be managed.
Dr. Samir.
So my one-line message is fatty liver alone does not cause liver-related issues in the short term. So the endocrinologist should be, or physician should be managing. But if the FIB4 is high, then the hepatologist needs to be in the picture to assess the liver and guide accordingly as far as the liver status is concerned.
Thank you so much for a very lucid, clear, crisp one-liner message. With that, we come to the end of the formal presentation. I thank all the participants, especially the Abbott team, for having organized this. I'm sure some of the comments and the discussion would have been pretty useful for you. We'll look forward to your feedback. Till then, goodbye and thank you so much, everybody.
Thank you.
Thank you, Anil.